Today I will be taking your lecture on diseases of infancy and childhood. As you know, this is the part 2 lecture. We have already finished the non-neoplastic lesions. Today we will be going to the neoplastic lesions. Okay. So why neoplastic lesions of infancy and childhood are so important for us? Okay. Because the first thing is there are these familial syndromes which are most commonly associated with childhood disorders, and secondly the prognosis, the survival. You know, we can change the survival of the children who are having these kind of cancers or malignancy, and we can give them a better life and better outcomes. So that is why the study of these things are very important for us. So as you can see here we have like the age wise distribution of the various disorders in various age groups. So yes, up to 15 years we have quoted here, and this image is from Robin, so all of you can go through that. So basically up to 4 years the most common neoplastic lesions which we get are majorly the primitive ones, okay, commonly like the retinoblastoma, neuroblastoma, Wilms tumor. These three names you should be remembering entirely, it should be in your brain. Then up to 5 to 9 years a bit of neuroblastoma stretches here, and rest of it are all adult tumors, but yet leukemias are very common in this age group, okay. And then 10 to 14 years again leukemia comes in, lymphoma comes in, this is most common. Rest of it are not so common, but yes, for the namesake you should remember them. So what I want to tell you here is that the malignancies of childhood and infancy, they are basically consisting of this oma or blastoma at the end, which means that it is a primitive tumor, okay. Primitive means the cells which have not differentiated, which have not matured. So all of these will be small cells. There will be blue cells, there will be round cells. So the tumor is also known as small blue round cell tumor, okay. So the histopathology will be same for all of them, so you will not have much problem in understanding it. We will go into each and every tumor in detail, but as per the thing, you guys are needed to study only two major tumors. One is neuroblastoma and one is Wilms tumor, okay. In your course you have to study that. Retinoblastoma will be taught detail in ophthalmology in 3rd year, and other tumors will be taught in respective chapters. So here we will be studying only these two tumors. So coming down to neuroblastoma. So what do people understand by neuroblastoma basically? Neural tissue is divided into central nervous system and peripheral nervous system. Now the peripheral nervous system has got sympathetic and parasympathetic chain. So in that we have the sympathetic chain getting involved. So the most common organ here is adrenal gland. In that the medullary region, the adrenal medulla is the one which is the commonly affected, the normal sympathetic region. So in case of neuroblastic tumors are various names, I will tell you as we go into the histology, but out of that commonly seen is neuroblastoma. So adrenal medulla is the one which is most commonly affected, and as you are aware from your anatomy that the sympathetic chain goes along the vertebrae. So the paravertebral region is next most common site for such kind of tumors, okay. Apart from that, posterior mediastinum can be affected, and also we can see in pelvis, neck, brain, other areas, okay. But most common being the adrenal medulla and paravertebral region, do not forget that. Now how do these tumors present? So grossly they can be very small, okay, very small, and they can go to very large tumors. So the smaller ones will spontaneously regress. There might not be any clinical presentation, you might not even know that the child had such a tumor. When the person later on in his old age dies, because of some reason you do autopsy, you might get it as an incidental finding, but otherwise you will never come to know the person even had a neuroblastic tumor, okay. Now that is what is the gross size. Now how is the tumor appearance? The tumor can be very well, very well circumscribed, it can be sharply demarcated, yet at times it can be very infiltrative, okay. Classically it is soft grey tan in color, and if it is a large tumor you will see hemorrhage and necrosis both, obviously. Histology, as I had told you, all of them will be small dark blue round cells. How they will be, I will show you, and I will tell you about these rosettes when we see the image, okay. So to confirm the diagnosis of a neuroblastic tumor, we use some amount of proteins, that is known as immunohistochemistry. The most common one which we use is neuron specific enolase, NSE, but this is not used much now because it's losing its specificity and sensitivity. So we are using a new marker now which is FOX2b. For you people, you do not remember it so much. but yes, for your exam purposes you should complete the answer sheet by writing them. Okay. Now I was talking about this, that in histology I will help you explain what is the neuroblastoma and what are the other parts. So these are all neuroblastic tumors. So whenever the primitive component is highest, okay, that is known as neuroblastoma. Whenever there are the neural cells are showing bit of differentiation, you will get something called as ganglion cells. I'll show you in the histology image. So those ganglion cells, when they are present bit amount and more of the primitive cells are associated, both of the tissue is present in histology, it is ganglion neuroblastoma. When the ganglion cells are more and the neuroblastic, the primitive tissue is less, it is known as ganglion neuroma. Okay. And with that, where you know the nerve tissues, the Schwann cells, when the Schwann cells are present, they are more towards the favorable diagnosis because it is becoming even more mature. Okay. So that's what is the Schwannian stroma. I'll show you all of them in image, so do not worry. Okay, before we go to the image, this is a staging of neuroblastoma. You do not know it in detail, but you should understand why the staging is so important and what is favorable and unfavorable. So basically it is based on the complete excision and the lymph nodes involved. In this I want you to be attentive on this stage. This is 4S. Okay. So being stage 4, still it is coming under a good prognosis or favorable prognosis. Why? Stage 4 is always associated with metastasis. Okay. So same with stage 4S. But here what is happening, the primary tumor is localized. It is not spread up. It's not a huge tumor. It is not like infiltrative. It is localized and it is well demarcated tumor, but it has disseminated to skin, liver or bone. Okay. But the dissemination rate will be very less. It will be like less than 10% cells, and it will be very, very less compared to the stage 4 where the tumor load is very high, has a better prognosis. And the irony is it is limited to infants of less than 1 year. Why it is so, we are still researching, but yes, that is how it is presenting. Okay. Fine. So now here I was telling you about the staging. So what is the favorable and unfavorable staging? You don't remember all of them, but some points are really important. So as far as staging, of course, the lower the stage, the better the prognosis, and in that 4S is one exception. And of course, the higher the stage, the unfavorable it is. In age group, as I was telling you that neuroblastic tumors happen by 9 years or 10 years of age, but the median age is 18 months. Okay. So if the child is less than 18 months, the prognosis is very favorable. If it is more than 18 months, then the prognosis is unfavorable. Okay. You remember those. And then in histology, as I have already told you, presence of Schwannian stroma and gangliocyte is a favorable prognosis. So just remember this. And in genetics, just remember this MYCN and 1P and 11Q. They are easy to remember. MYCN is the most, it's called MYC gene. So MYCN gene is the most commonly affected gene in neuroblastic tumors. So whenever there is presence, whenever it is amplified, it will be unfavorable. Okay. And loss of 1P and 11Q is unfavorable again. So these are the various genetic alterations which you should know. Okay. Yeah. So moving on to the next slide. This is what I was telling you about the gross appearance. So this is the normal kidney. Okay, this entire organ belongs to a pediatric person, and in that this is the normal kidney, and this is the entire adrenal gland. So you know, adrenal gland will be so small that whenever we get nephrectomy specimens regarding cancer or cystic areas or something, it will be very difficult for us to find. But here the adrenal gland has gone for such a big change and it has become malicious. So you can see greyish areas and some amount of soft tan areas, and yet the tumor is present only in the adrenal and it has not spread down to the kidney. Okay. Now this is the corresponding image. This is what I was talking to you about, that the more the primitive cells, the more blastoma it is. Okay. So this is neuroblastoma, and you can see small round blue cells. All the cells are small round blue cells, and this is forming something like canals. Okay. And inside that, if you can make out, there is some pink color substance. These are called as neuropil. So this entire thing is called as a true rosette. A true rosette is the one which is formed by the cells around, and there is neuropil inside. So this is a true rosette, and the name of such kind of rosettes given are, one of the examples are homorite rosettes, which is most commonly seen in neuroblastoma. Okay. Now there is one more image. Yeah. So I was talking about this, that ganglion cells. So these are the next stage after the differentiation from these small round cells into the ganglion cells. These will be bigger cells, they will have a big nucleus like an owl eye, they will have a prominent nucleoli, this pink color thing, okay. So these are ganglion cells, but you can see there is some amount of primitive cells present. So that's why this is a case of ganglioneuroblastoma. There is some percentage for the distribution of gangliocytes and the primitive cells. It's not important for you guys to know, just remember how it is differentiated, okay. And the next one, yeah. So the next one here is the ganglion cells, and you can see this is the nerve cells, the mature nerve cells, right? So this is a Schwannian stroma. So that's why the entire thing is now known as ganglioneuroma. So it's a mature cell. So that's all about neuroblastoma. We will switch on to nephroblastoma, that's Wilms tumor. So the second tumor, and this is very, very common, especially in the United States, it's very common. It's the fourth most, frequent carcinoma seen in infants. And also in India it is very common, okay. So that's why we need to know about this. So it's otherwise known as Wilms tumor, and it's the tumor inside the kidney. So what is happening here? Of course, when kidney is getting involved, so the features will be all abdominal. So clinically we will get abdominal distension, the child will be having abdominal distension, may have pain in the abdomen, definitely will throw hematuria. That is the most, the commonest thing which a mother will get to you as a complaint of hematuria. Then you have to look for all these other findings, and you have to do your scans and you have to find out. Hypertension, sometimes yes, pediatric hypertension we do get, but we do not commonly diagnose it much. So hematuria is the first clue for us. The age group in which Wilms tumor is happening I had already showed you. So it's within 10 years of age, but most commonly we see by 2 years of age, okay. Grossly, the tumor will be very large, it can be well circumscribed, it can be infiltrative, and it will be usually a single lesion, solitary lesion, can be soft, and it can be homogeneous. Greyish white to greyish brown, there is nothing much characteristic about the Wilms tumor appearance in grossly, but yes, the location is, from that we diagnose. Sometimes it can be solid or cystic, and if large it will be definitely having hemorrhage and necrosis. Now the histology here, as I was telling you, it is a small round blue cell tumor, right? In nephroblastoma we find this small round cells getting differentiated into three of the germ lines. So what are those three lines? First they will form the epithelial component, they will form the stromal component, and they will form the primitive component, which is the blastemal component. So you will get all these three things in this, okay. So I'll just try to explain you. Now this, what is this anaplasia and poor prognosis, I'll let you know in histology. Yep. So this is the normal kidney, and this part, this brownish part, and this white one is the tumor. So this is your nephroblastoma, and there is one more small white foci here. I don't know how much you are able to appreciate, but still if you differentiate from the brownish surroundings, you will get this whitish area. So this is something, these two are the tumor zones, and this is the normal zone in between. So this is a case of Wilms tumor. Now when such two tumors are present in the single kidney, if they are happening simultaneously, it is called synchronous distribution. And if say this tumor developed first and later on this one develops after you have resected or something, that is called metachronous distribution, okay. So that is what it is grossly about. Now just have a look at the histology I was talking about. So here also you can see that there is not much differentiation. These are the small round blue cells, but these cells are somewhere trying to form abortive tubules or abortive glomeruli. Glomeruli are not seen here, these are the abortive tubules. So this is the epithelial component what we are getting to see, right? And these are the entire primitive zone. So these are the blastemal regions. Blast or blastoma or blastemal are always synchronous with primitive regions. And the rest of it will throw mesenchymal element, that is the spindle cell. But these are all derived from the same primitive cells, okay. Now these spindle cell zone, they can go for fatty differentiation, they can go for cartilage differentiation. Yes, I know it is bit of maturity, yet this will be labeled into the Wilms tumor itself, okay. So this is about all the tumors I was trying to tell you. One second. So this is about all the tumors I was trying to tell you. So from this lecture you can take home that there are two diseases which you should be knowing thoroughly. One is the neuroblastic tumor, one is the nephroblastic tumor, okay. and these two tumors are very common in our country. So see, everybody addresses the adult people, okay, but people do not understand that even kids face these kind of challenges. So treating them, and before treating you have to diagnose them correctly. So that's why these things are very important. So you should study and you should understand them. Okay, thank you so much.